Assalamu alaikum. Today, inshallah, we will talk about cervical myelopathy. In the previous lecture, radiculopathy, the pathology compressing the root. So we have radiculopathy. But here, the same pathology could compress the cord and doing a damage inside its substance. So it is a cordomalacia, damage in the cord. This damage of the cord presented in the MRI with signal change together with clinical manifestation, some special clinical manifestation. This is called cervical myelopathy. So the same pathology for the radiculopathy could be in myelopathy. But the term myelopathy needs radiological plus clinical manifestation. Pathogenesis, the etiology, the same as radiculopathy. Spondylitic changes started by disc degeneration, then osteophyte in the spur in the ancovertebral joint, OBLL, and so on. Posterior longitudinal ligament, its ossification due to its location, it could cause myelopathy rather than radiculopathy. There are plus two other pathological terms, kyphosis and congenital cervical narrowing. Kyphosis, for example, post surgical, you are did laminectomy, for example, multi-level, so he lost the posterior support for his neck, so you can kyphosis could compress the cord. Congenital narrowing, he is congenitally born with narrow canal. Usually, the cervical cord usually occupy about third the diameter of the canal. But with progressive aging of the patient and progressive spondylitic changes, if he is already congenitally narrow, he can't adapt for this aging and spondylitic changes and could be manifested earlier. Natural history for radiculopathy was spontaneous resolution. Here, no. So the rule there was conservative management. Here is a stepwise deterioration. Stepwise deterioration. He get some period of plateau, then progress to further neurological deterioration. He is generally regress in his general condition, then plateau, then downward, plateau, then downward, and so on. So the rule here is operative, not conservative. But you have to inform your patient that the operative management isn't for returning to his even near normal. The main goal of the surgery here is to hold the progression, not to improve his manifestation, which I will tell you. History and physical examination. Detailed history, detailed examination in spine examination, but we have to focus for this cervical myelopathy. He has a constellation of symptoms between upper and lower limb, both. Radiculopathy was only upper limb. Upper limb, he come to you and complained that he couldn't use his hand well, despite he didn't feel it is weak. Despite the damage in the cervical cord, he didn't feel any weakness, but he couldn't manage his fine movement, like, for example, writing. he feels that his lower limb is good, not weak, strong, but he can't, he feel unsteady gait. He couldn't walk well without support, despite he didn't feel a weakness. So upper and lower. Okay, lower limb manifestation in the form of unsteady gait is called Romberg sign. For normal walking, you need eye and ear, good ear and good eye, and the sense of proprioception of the joint received by the posterior column of the cervical cord. So 3 components you need normally, but you can manage with 2 components. So if you have a damage in the posterior column in cervical myelopathy, still you can walk steady. But when you are informing the patient, if in, okay, but in Romberg test, he closed his eye. So he has now an intact middle ear only. So he has an unsteady gait. This is early. Late? No. He couldn't. He has unsteady gait. Sperling test in radiculopathy to differentiate cervical and shoulder pathology mainly was extension and tilting, rotating the head to the same side. He feel paresthesia or pain in the upper limb. Here, Lermite sign. Lermite sign is for cervical myelopathy. Just when you are doing some flexion to the neck, he feel electric shock-like sensation is in his lower limb, even in his lower limb, because of that narrowing in the cervical canal. There is a lot of causes can cause unsteady gait and the manifestation of cervical myelopathy, but not in the cord itself, in the brain, for example. For example, shock, stroke. For example, stroke. To differentiate, you have jaw reflex and scapulohumeral reflex. When you are tapping at the inferior angle of the scapula, you have an hyperabduction of the shoulder. This is indicate upper motor neuron lesion. Upper than the cervical, above the cervical region. There is a reflexes. One of the reflexes which I inform you was the brachioradialis reflex. If he has a flexion of the elbow, this is the brachioradialis reflex. If he has flexion of the finger, this is inverted brachioradialis reflex. So the same technique but different result. Inverted brachioradialis reflex is sign of upper motor neuron lesion. For the lower limb, upper motor neuron lesion by Babinski, lower limb and the clonus, Babinski and the clonus. Okay, this is the why he have Romberg sign when he closed his eye, and he didn't have before he closing his eye. I inform you congenital narrowing of the cervical spine. In the imaging, plain X-ray could detect this congenital narrowing. Suppose that the distance between the posterior border of the vertebrae and the spinothalamic line, spinolamellar line, this part is the posterior part of the spinous process, and just the attached part is the lamina. So this line is spinolamellar line. So point from here to the posterior body is the canal, and this is the diameter of the body. Suppose that half and half. Suppose that its ratio A to P is about 1. If A below P, it will be suspected that he has congenital narrowing of the cervical spine. Also, this is a CT, sagittal CT, showing the ossification of posterior longitudinal ligament. MRI is difficult to differentiate between posterior longitudinal ligament ossification and the disc. So the CT, to detect the extension of the ossification of posterior longitudinal ligament and differentiate between soft and hard disc. This is MRI. This is what I mean. This is a signal change here and there. This is a 2, 3, 4, 5. So signal change between 4, 5, 5, 6 here. Plus clinical manifestation is a cervical myelopathy. Differential diagnosis as usual. A lot horrible differential diagnosis as cervical myelopathy, as cervical radiculopathy, but myelopathy also can caused by brain. Mainly, you have to exclude cervical myelopathy from, for example, stroke by jaw reflex and scapulohumeral reflex. Non-operative management, there is no rule. Actually, there is no rule. This is cervical myelopathy. Surgery is the treatment of a choice for symptomatic, and there is a debate regarding asymptomatic. You can decompress cervical spine, cervical myelopathy, either anteriorly or posteriorly according to what you have. What you have regarding the pathology. The pathology, you can manage the anterior or you can manage posterior. This is a general rule. But if you have marked kyphosis and you manage posterior, it will progress for more kyphosis. The angle, if better, if you have a kyphosis, kyphotic angle, more than 14 degrees, to avoid posterior surgery alone. You can do posterior with anterior surgery. So if you have a lot of kyphosis here, you have to restore your cervical lordosis by ACDF. Also, if you can choose between cervical and posterior. Posterior is better for multi-level, more than 3 level, without significant kyphosis. So, kyphosis angle and the number of the affected level guide you either anterior or posterior, or you can go post approach, cervical and anterior. Some severe cases I have to go posterior just to open the spinal canal to give me some spaces for decompression anteriorly. Also, you can remove one of the cervical or two of the cervical vertebrae and called corbectomy. So you have anteriorly ACDF, anterior cervical discectomy and diffusion, or corbectomy, anterior cervical corbectomy, or posteriorly by either laminoplasty and or laminectomy with or without fusion. For posterior surgery to adequately decompress the cord, however, enough lordosis must be present to allow cord drift back after removal. If there is a kyphosis and you open posteriorly, you didn't give a space for the cord. He has to be lordotic. You can combine anterior and posterior. Laminoplasty means that you remove the lamina on one side. You remove the lamina on one side, so better stability and preserve the motion. But I don't think that it is done nowadays. Posterior fixation, posterior decompression is done mostly with fusion through lateral mass. Lateral mass screw fixation has different types. The lateral mass, as I informed you before, is the space between the facet above and the facet below. This is the superior articular process and this is the inferior articular process. And the facet inclined about 45 degrees. I can make 4 quadrants of the facet. This is a vertical line and this is a horizontal line. And put a screw just medial to the midline and go laterally, directed laterally and above. I inform you, you can put a needle in the facet here to take the trajectory of the direction, and you have to go laterally to avoid the vertebral artery. Vertebral artery is in front here. This is the transversal process and foramen transversarium about here, so you have to go laterally. This is the lateral mass screw fixation, whatever the. I inform also you about pedicular screw in the cervical spine. It is so dangerous because it passes in the corridor between the nerve, spinal cord and the vertebral artery, and the well-developed pedicle is only C2 and 7. So we didn't put pedicle screw personally except in 7, C7, because it has no vertebral artery in foramen transversarium and it is a well-developed pedicle. Could take at least 3.5 milli pedicular screw in diameter. And when you have to reach the pedicle, you have to go. The pedicle arises from the posterior part of the body. So you have to go to the lamina above, superiorly, and you have to go laterally. So far laterally, as I informed you before. At C7, most patients don't have a vertebral artery, so you can put a pedicle screw. At C2, the vertebral artery is generally very laterally, and you go medially to go to the vertebral body, to the insertion site and trajectory of the pedicle. Making pedicle screw fixation can be done. From C3 to C6, you have vertebral artery and smaller diameter pedicle. Insertion of pedicle screw, as I inform you, generally you have to go far laterally and superiorly. Far lateral and superior. This is the direction of lateral mass screw, directed laterally. So you have to start just medial to the midline. After doing 4 quadrants of the lateral mass, you have to go just medial to the starting medially to go laterally and avoid the vertebral artery. In the pedicle arise here. So you have to start so far laterally to go to the body to avoid and incline medially. This is just the difference between the lateral mass screw and pedicular screw. There is another rule just to see where you are. You can take part of the medial part of the lateral mass to see the pedicle by yourself and feel with the probe to feel and take the sense of your trajectory. So simple laminoforaminotomy can aid in your direction. C2 pedicle screws, the general rule is starting laterally and above. Please comment on the X-ray. X-ray, this is a lateral X-ray. There is mostly a narrowing here with anterior osteophyte, little bit. C2, 3, 4, 5, 6, 7. Cervico-thoracic junction, I couldn't see well. So please, I want adequate X-ray. Don't go to the MRI before asking about AB X-ray. This is the MRI. What you see, as you see, CSF is whitish regarding to the spinal cord, so it is mostly T2. There is 2, 3, 4, 4, 5 disc, 5, 6 disc with some signal manifestation. This is the axial manifestation. If he has, with this investigation, how would you manage this patient? You have to take a proper history, proper history and proper examination to feel, to see what the patient needs. If he is symptomatic with upper and lower motor neuron lesion, he has to be decompressed either anteriorly or posteriorly. Would you offer anterior or posterior, and why? You have anterior or posterior according to the pathology. Where is your pathology? Is it anterior or posterior? What is the kyphotic angle? How many levels you have to attack? Would you offer anterior? I say, what about isolated laminectomy without fusion? What about isolated laminectomy? Laminectomy without fusion is very dangerous. Laminectomy means that I have to remove the lamina. Lamina without, so what is the posterior stabilizer of your cervical spine? It will go to into at least for instability. So you have to fuse it with most commonly lateral mass screw. Post laminectomy, kyphosis or instability. Rarely indicated because of post laminectomy kyphosis, which is one of the causes of cervical myelopathy and instability. The patient has read about cervical disc replacement. Cervical disc replacement to treat, one of the options, sure, but to treat you have a good facet. Facet, you have intact facet. You have intact ancovertebral joint. In cervical disc, the aim of cervical disc replacement is to preserve motion. So if the motion of the spine is dependent on the facet. So if the facet is defective, so what is the rule of cervical disc replacement? We use cervical disc replacement or in general prosthesis replacement either for cervical or lumbar in younger age need the motion, need to preserve his motion and one level, and the posterior facet is intact, so he can but for older age I don't think that he is in need. What is the outcome after anterior surgery with fusion? The primary goal for cervical radiculopathy surgery is to halt progression, not for neurological improvement. Inshallah, he will neurologically improve, but no, this is not the aim of the surgery. Thank you so much.